Our last little chapter here in this first section is genetics. How many of you like genetics? I don't see too many hands. Did you have a genetics class? Or maybe you had content? And don't get scared now. And I'm gonna cover it very gently, but I have to tell you, when I was teaching at Emory, I actually have a certificate in genetics. I really enjoy genetics because it's the framework of what? Health and illness. It's the basis of everything we know about what's going on with our health. So this chapter is going to be extremely important. It's going to be an assessment chapter. You are not going to manage these kids per se, but you're going to keep more. It's going to be your assessment piece. And can you imagine that it's been, when did they map out the human genome? 2006 June. It's been 6 years. Isn't that exciting that they've got all that mapped out? We know so much more. Genetic advancements, we think about major malformations, 2% of live births. 80% of these do have a genetic cause and an increase of recurrence. So when you advise parents, especially you work with young parents who are in childbearing age, the empiric risk of having another child with a condition is going to be greater. That makes sense, doesn't it? And only 40 to 45% genetic disorders are diagnosed in the neonatal period. And if you work with young infants, 80% are identified before 6 months. So there's going to be patterns of things that you are going to be in the right position to identify. We also know that advanced paternal, let me correct that, parental age, both female and male, do contribute to some of the conditions you'll see. History, those families that have a history of miscarriage, stillbirths, family history with birth defects, mental retardation, growth retardation, neurological conditions like seizure, and anything that's familial. Can I just take a moment and just remind you of two main terms? Do you remember autosomal dominant? Autosomal dominant means that it's dominant it presents in every generation. One good example of autosomal dominant is bipolar disease. Okay? And so when you have somebody that has bipolar, you're likely to have other first-degree relatives, and it will be present in every generation. What about autosomal recessive? You could skip generations until the right mix occurs. Can I take a moment and go over that with you and just have you remember this? Do you remember using the Punnett square or doing cross multiplication? Y'all remember that? Okay, I'm going to put this down, my hand down here. But the reason I'm saying is you have two parents that carry the gene. So in other words, in their generation, it was not present per se. The probability is always the same, no matter if they've had one baby or 8 babies, 8 pregnancies. It's always going to be the same. So each of them carries the gene. If you cross multiply or use the Punnett square, you're always going to have 25% chance of being unaffected, 25% chance of being affected with the condition, and 50% chance of having the gene to carry it on. It's the match of coming together that makes you have it present or not present. So you can have several generations. One good condition to think about would be sickle cell disease. That is an example. Okay. So when we go on, we think about indications for genetic evaluation, fetal exposure to medications, intrauterine infection, radiation, toxic chemicals, illegal substances, also ethnic background. As we know that there are, for example, sickle cell disease, usually populations of color, African American, Mediterranean descent, and so forth, typically have a higher prevalence. Guess how high it is? The prevalence of sickle cell, which I'm going to go over, so don't get worried if I give you a little term here, but I like to use this in terms of perspective. 1 in 400. That's pretty prevalent. Can I just give you another little sidebar? Guess how prevalent Down syndrome is? 1 in 660. Pretty prevalent. Pyloric stenosis in children, when we do GI, 1 in 500. Did you know that? So even though I'm giving you these terms, I give that to you for those of you who are taking this in terms of review. It's nice to take that occurrence rate information and put it in perspective as to the population you serve. One thing, too, to think about with PKU, can I tell you about PKU, what a typical PKU baby looks like? They're Caucasian, blonde hair, blue eyes, and they often have flat feet. Now, isn't that interesting? Flat feet. Isn't it interesting? So what's going to happen is, what I'm trying to tell you is you're looking for patterns, okay? And we're going to go through and we're going to see some of these others that as examples. Do you all remember the term phenotype versus genotype? Let's take a look at that. The way to distinguish phenotype from genotype, and I'm going to come walk over here because I don't get to see y'all too much over here. Phenotype, and I keep forgetting because usually I'm tethered to the thing over here, so this is nice, I get to walk around. Phenotype means what you physically observe. So it may be a physical finding, it may be a physical observation, the way a child behaves. So does that make sense? Now, genotype refers to diagnostic studies, your genetic tests, your lab tests. Okay? So let's take a look at what this says up here. Phenotypical presentation specific to genetic disorder may include dysmorphic features. Do you remember the old FLK? Funny looking kid? And I always hate to say that because to me that sounds disrespectful, but FLK means that the child has either dysmorphic features or subtle dysmorphic features, right? Developmental delay, normal intelligence, mental retardation, that's something you can observe, how a child behaves in class and observe their grades and so forth. Short stature, failure to thrive, progressive deterioration, seizures. I will tell you, a lot of your genetic conditions have two components. Usually there's some type of a cardiac component and some type of a seizure disorder or neurological. We also know genotypical presentation, as I mentioned here, is diagnostic characteristics. Do you all remember doing a genogram or a pedigree for your families where you map out 3 generations, you go back 3 generations, you map out, the male, female, if they're, alive and well versus deceased and what kind of condition they had. And you can sometimes see certain conditions, whether or not the pattern is there. We also know prenatal screening and diagnoses, and tomorrow, for the adults, because it's going to be on the family, we're going to talk about the pregnant woman, and we're going to do prenatal. So the peds folks, we don't delve into that in great detail. So we're going to go through a couple of conditions, and we're going to look at genetic factors such as syndromes, certain features. So you're going to observe this baby, you're going to look and see certain factors, and we're going to start off with Down syndrome. And I'd like to share with you that if I had to pick out 2 that they really like to kind of zero in on, pink pig, Down syndrome, and Marfan's. We're going to spend time with both of those. If I could also preface for the pediatric folks, show me again, pediatric folks, where you're sitting. I know you're here. Okay. The pediatric folks, they usually have been keying in on either Turner's or Klinefelters, and I've been hearing Klinefelters lately. And let's see, DeGeorge at the very end, okay? So I'll go through and we're going to talk about these from an assessment perspective. Now, Down syndrome is 3 number 21 chromosome. Occurs in 1 in 660. Did y'all realize it was that prevalent? It's kind of interesting to think about that. Increased maternal age risk does increase the risk, and degree of retardation ranges from mild to severe. We also know about some of the physical findings. Look at this, microcephaly, flattened nose, protruding tongue. Do you know this is the inner epicanthal folds in the inner side of the eye here? Protruding tongue. You know why they got a protruding tongue? Look at this down here. This is really key. Hypotonia. They can't keep the tongue in the mouth. They have low tone. Do you remember also with children with Down syndrome sometimes have that characteristic transverse crease on their hands? It's usually bilateral. Again, it's because of hypotonia. Think about this. If you were all balled up in utero and you had low tone, don't you think you're going to have more creases than anybody else? That's the reason. Now, I will tell you, the general population, 10% of the general population will have a unilateral transverse crease. These kids have bilateral. And again, hypotonia is keyed in. Short, broad hands and fingers and delayed growth and development. Some other things to think about, too, here is they typically have seizures and a congenital heart disease. What's the most common congenital heart defect? VSD. She mentioned VSD, and if I could broaden that a little bit, it's any type of a septal defect. It could be atrial, ventricle, or both. You could have both anywhere along the septum. You may have also heard that being referred to as endocushion defect. It's the cushion in between the ventricles. They have endocrine abnormalities like diabetes, esophageal atresia, hearing vision impairment, obesity, leukemia, and early dementia. As a matter of fact, a lot of children who have this will have dementia as early as 30 to 40 years of age. So you can see the range of care that would go into a child with Down syndrome. Now, for the pediatric folks, and can I just make another little sidebar for you? Every now and then something comes to mind, I think about a sidebar. There may be some information. I want you to take things away. The F&Ps, like I said, 33 to 38%. And I'm trying real hard to direct you into where I see more prevalently the questions that may occur for your exam. But the F&Ps, take what you feel is important to you. If you think, I'm probably never going to see a Klinefelter's child, that's okay. But you may hear some things here, too, that is going to be helpful to your practice. But for the peds folks, this has been something that has been notable on the exam. So here's a pink pig. It's an extra X chromosome, mainly in males, only in males, excuse me. So when you think about this, if you have an extra X, what are you going to have? A little more femaleness in terms of your characteristics, right? So 1 in 1,000 appears at birth, the baby appears normal at birth, but so you're not going to really see it until puberty. They are infertile. It's not inherited, so they cannot beget children. There's also hypogonadism or low T, low testosterone, and infertility, as I mentioned. They're tall. They have transverse creases. Body proportion is abnormal. They're kind of tall and lanky. Underdeveloped secondary sexual characteristics, gynecomastia, breast tissue in the male, learning disability, and personality impairment. And this is what you think about. We think about poor beard growth, minor breast development, female hair, testicular atrophy, and just tall. And what do you think this genotypical presentation would be? What is this called? Does anybody remember? A karyotype. Y'all remember the word karyotype? So when they map out the chromosomes to find out. So for example, here's your XY. And so I can clearly see on this genetic test that this child has a what? Extra X chromosome. Does that make sense? So genotypically, this is showing me this. Plus, phenotypically, I've seen all the other features. Okay, here's Turner syndrome. Turner syndrome is missing, this is a female, so it's the most common sex chromosome anomaly in females. 1 in 2,000 live births. 95% of embryos do not survive to term. They don't have the X, they have the X, but they don't have the Y chromosome. I will tell you, many of these babies, 95% of them, don't even survive to term. These are the babies that are what? They're called puffy babies. In utero, they're extremely lymphedemic. Lots of edema. Because guess what? If they survive to term, that fluid starts to be what? Absorbed, and that's what leaves them with webbed neck. Did you ever think about how that works? Because they were extremely stretched and puffy, lots of fluid. Then if they make it to term, the fluid begins to be absorbed, and then the remnants is the webbing. They also have low hairline, learning disabilities, secondary sexual characteristics, shield-shaped chest. That means widely spaced nipples. And in the future, I'm going to talk a little bit more about Turner syndrome. Head and neck abnormalities, like different types of tracheoesophageal anomalies where they have connections between them. Hypertension. Can anybody tell me what's the most common type of congenital heart defect for a child with Turner syndrome? Do you know? Coarctation of the aorta. Anytime you think of hypertension, think about something that is obstructed. And so coarctation of the aorta is common. This is showing you here, let's see, we think about children with hair irregularities. Hair is an extension of the skin, which is the largest organ. And whenever you have hair irregularities, or what we call two whorls, it reflects brain growth. So that would also reflect maybe some learning considerations. Now here's Marfan's. Marfan's is the next one we want to talk about. Inherited connective tissue disorder. The skeleton, cardiac, and ophthalmic body systems are affected. And just to note here, like you can have pectus excavatum. We think about they're very tall. Their arm span exceeds what? Their height. So they're very long, lanky. Again, is the connective tissue. Thin extremities, long face, pectus carinatum, hyperextension of the joints. And you can also think about their palate can be high arched, narrow. But the thing to be most concerned with, say you have a teenager that comes in for a physical for sports, and you have suspicion of Marfan's. Well, you probably want to do what? Not clear them for contact sports because of this. Aortic regurgitation, mitral valve prolapse. They are at risk for having an aneurysm. And you remember the term aortic root dissection of the heart? That is tied into this. So that would be a real key point. Here's a unique another condition that I don't think is often assessed with the certification exams, but just to look at another special population, the Ashkenazi Jewish population. Normal at birth and deterioration begins at 3 to 6 months. And look at what occurs. They go through a process of decreased muscle tone, listlessness, blindness, deafness, seizure, dementia, vegetative state, and death. And DeGeorge. Pediatric folks, every now and then you'll see an assessment question on this. This is a congenital defect of the parathyroid gland, thymus, and conotracheal region of the heart. And when you think about this, this is where you have increased susceptibility of infection, mainly because of the thymus aplasia. They may have some abnormal facies, which I'm going to show in a few moments. Congenital heart defects such as aortic arch anomalies, hypoparathyroidism with low calcium. And whenever you have that, you always have the risk of seizures, cognitive behavioral psychiatric disorders. And now facially, the micrognathia. Micrognathia means receding chin. Remember that term? And facial features that look, I don't know that I would consider these to be some subtle dysmorphic features. I don't like to say FLK, but you can see here subtle dysmorphic features. Okay? That wasn't too bad, was it? No. So you got some little pointers. What would you say that chapter was mainly about? What would you say? Probably it's mainly about what? Assessing. Keeping a good assessment, keeping your assessment skills up.